other human papillomaviruses. We'll go through some introduction, which will, as I mentioned earlier, we'll cover a little bit on other STIs. And then I will go into, we'll start diving more into the epidemiology and the biology on HPV and the treatments and the prevention measures that we have available. So a sexually transmitted infection, as the name suggests, is an infection that is acquired through sexual contact, though not exclusively through sexual contact, but that can be one of the routes of transmission. And that includes what we call sexually transmitted diseases. So what do you think a sexually transmitted disease is? What would be the difference? What do you think is the difference between a sexually transmitted infection and a sexually transmitted disease? Any thoughts? Any thoughts? Anyone? Oh, I see some of you asking about the herpes class. I think that was meant to be covered in another class. But you can always find out whether there was some miscommunication and then find a way of making up for that. Or were you guys expecting a herpes class?
No, herpes is with Prof. Oyugi.
Okay. So what would be a sexually transmitted disease? Any thoughts? Yes, an STI is transmitted through sexual contact and is a microorganism. So how would that differ from a sexually transmitted disease? Thanks, Joroge. Anyone who wants to take a guess? I can see that there are many people. Out of, okay, so let me just make it quick. Yeah, infection is the initial step. So that is the answer that I was looking for. So, because not every infection leads to disease. So a sexually transmitted disease is when you have disease manifestations. Because you will see that there are many infections that will just remain latent or quiescent. So those ones you will not call them STDs, you just call them STIs. And we have STIs are quite common, and you have almost approximately 1 million people acquiring an STI every day. And as we mentioned earlier, there are many STIs that are asymptomatic and will therefore not qualify to be STDs. And you can see the numbers that account for STIs every year from just 4 of the main pathogens that are the culprits for causing STIs, where you have at least 500,000 people getting actually STDs. So these are this particular STIs usually almost cause STDs in the majority of the people who acquire infections: chlamydia, gonorrhea, syphilis, and trichonoma vaginalis. And then you can see another viral STI, herpes simplex virus 2, which causes genital herpes. Around almost 500,000 people have it globally. And you can also see HPV, which is of interest to us today and causes cancers and warts. More than 500,000 people have it globally. So STIs can have, when they cause disease, they can lead to various long-term complications. You can have genitourinary tract complications, which would be expected because that's the main site of manifestation. And this can have long-term implications on fertility levels, leading to infertility, causing higher risks of ectopic pregnancy. Some of them also cause cancers, mainly in the genitourinary tract, but also elsewhere, like in the liver, in the oropharyngeal areas, they could cause cancer. And others can just cause lifelong infections like HIV. And some of them can also get transmitted to the unborn child or during birth, like for HIV, for instance. And also, some of them, sometimes they also have interactions amongst themselves, whereby you find if someone has other STIs, they are more likely to acquire others because they breach the mucosal barrier in the genitourinary tract. So like people who have some of the bacterial STIs are more likely to acquire HIV because of that breached mucosal barrier, and also because of increased inflammation in the genital tract, which increases the chances of acquiring HIV. Others can cause diseases in remote organs, like in the CNS. Like you can have neurosyphilis in the liver, you can have hepatitis, which is one of the STIs, can cause liver cancer. And also, we should not forget the mental health impacts of STIs, especially because they are highly stigmatized and people might find it very difficult to get the required treatment. So we have mentioned that some STIs are bacterial, like Neisseria gonorrhea, Treponema pallidum, which leads to syphilis. Others are parasitic, like the most common, be Trichomonoma vaginalis. And you also have pubic lice and scabies are also recognized as STIs. But then it gets a little bit more complicated for viruses, so where you have quite a number, of which some of them will lead to unknown infections, while some of them will manifest much later on. Like HIV, which is the most studied one. And then the one of interest today, HPV. Then you have herpes viruses that you'll cover with Professor Yugi. And yeah, you have things like hepatitis B virus, hepatitis C virus. Also, some of the hemorrhagic fevers will also lead to, can also be transmitted sexually. Like Zika, there are reports that Zika can be acquired sexually. Ebola virus can also be transmitted sexually. Like there was a case, I think last year or the year before, of people who have Ebola virus persisting in their genital tract and they're able to transmit later on. So yeah, the main reason why they are classified as STIs is because they can be transmitted through sexual contact, which could be either through the vaginal or penile organs, through sexual intercourse, vaginal or penile sexual intercourse, also through anal sex, and also oral sex, so can also lead to transmission of STIs. And then actually some of the STIs like HPV can be transmitted through just skin-to-skin contact. Actually, that's the main route of transmission. So the main modes of transmission, being STIs, of course, that remains through sexual intercourse. But many of these viruses are also present in blood, and therefore blood and blood products can be a very sure route of acquiring an STI, especially those ones that can be transmitted through blood, like HIV, hepatitis B, hepatitis C, and then also some of the bacterial ones. And then there's a vertical transmission that is quite well documented, especially for HIV, where we have been able to control it quite well by administering antiretroviral drugs to pregnant women and also to the newly born child. And needle sharing for people who are using drugs, they tend to share needles, and that has also been a major route of transmission, and it is actually a major route. It accounts for most of the transmissions in some of the countries in the West. And then anything else that entails exposure to poorly regulated piercing objects like tattooing and body piercing can lead to transmission of some of these blood-borne pathogens. So most of these STIs are also blood-borne pathogens. Basically, they are transmitted through body fluids. So anything that leads to exposure to infected body fluids could lead to transmission of these STIs. There are very low risks of acquiring most of these STIs through hugging, kissing, sharing cutlery, sitting on toilets. Social interactions basically are have a very low risk of transmitting these STIs. And of course, abstinence is a sure way of also avoiding acquisition of these STIs. So I thought it might be good, before we continue diving deeper into the viral STIs, it might be good to just have an understanding of the differences between the bacterial STIs and the viral STIs, or which the viral STIs we have said. These include HIV, HPV, herpes simplex virus, hepatitis B virus. Well, for bacterial STIs, we have the gonorrhea, syphilis, chlamydia, and chancroid. So all those are the different forms of bacterial STIs. But the one thing that I would want you to remember is that most of the viral STIs don't have a cure, and the only thing that we do is to manage the symptoms, whereas the bacterial ones are fairly easy to cure with antibiotics, as long as they don't have antibiotic resistance. And as long as you know the antibiotic to use, they are quite simple to cure. And so because the viral STIs are not curable, sometimes they remain as latent, but can be passed on to other people for the rest of the life, for quite a number of them, if their viral loads are high at some point. While bacterial STIs, their main issue is if they are not treated early, they could lead to lifelong infertility or scarring of the genitourinary tract, which could affect things like pregnancy and also functionality. And also they could also lead to what we call pelvic inflammatory disease, which sometimes can go unnoticed and lead to a lot of discomfort and also infertility. So let's dive into HPV, human papilloma viruses. So as the name suggests, the family is papillomaviridae. It's a fairly small virus. It has a small genome of around 5,000 to 8,000 base pairs, circular double-stranded DNA. It's non-enveloped, and there are as many as 200 genotypes so far, within around 50 genera, and then there are around 40 genotypes that are associated with anogenital regions, and these are what you call STIs. And some of them are associated with cancers, both in the anogenital region and also in oropharyngeal regions. So this basically is the initial part of the classification, which is the official classification, taxonomic classification based on the International Committee on Taxonomy for Viruses, where we classify them based on the general species and genotypes. And then we can also classify them based on the tropism. We have quite a number of HPV types that are mainly associated with cutaneous infections, where they either infect the skin or the feet or the hands. And then we have the ones that are mainly associated with mucosal infections, where they infect the anogenital mucosa or the oropharyngeal mucosa. And then we can also classify them based on the risk of leading to cancer. We have the high-risk genotypes, mainly, and this classification based on risk is mainly for the ones that infect the mucosal compartments. So we have the high-risk types that are associated with most of the malignancies that we see that are HPV associated. And when you have the low-risk types, that are mostly the ones that cause cutaneous warts, and also there are some genital ones, genitally associated HPVs that are also considered low risk. And these usually are the ones that cause genital warts. So the ones that are high risk don't cause genital warts, but they cause, they have a higher risk of causing malignancies. But the ones that infect the genital mucosa and cause warts are generally low risk ones. So you might be surprised that the ones that cause genital warts end up being the low risk ones, but that's just how it is. So cervical cancer is one of the main pathologies of HPVs. HPV has been associated with the infection of the cervix. Ordinarily, when someone is exposed to an infection, it will infect cells at the base. Some basal cells will get infected, and then as these cells multiply, they are multiplying with infection. They are also producing virus particles that infect neighboring cells. So you end up having the infection spreading, and then eventually, and in some of these cells get transformed, and they actually have the HPV DNA integrated in the cell. And these are the ones that eventually can develop into invasive cancer. So this usually progresses over time. And here I just got this slide from the Ministry of Health showing the progression. So when a normal cervix is infected, you can just have someone getting infected with HPV, and there's no pathology that develops beyond that. It's just the most common form of infection. But then this can progress to precancer and eventually to cancer. And up to the precancer level, you can also have regression, where the lesion improves over time, and also the majority of the people are able to clear the virus, so you can end up having a reversion all the way to normal cervix. So this is just showing an example of some of the observations from visual inspection of cervixes. You can see a normal cervix there, and one that is infected, one which is precancerous, and up to this level, it's possible for someone to go backwards. And but then in a few people, you have some people progressing to cervical cancer. So HPV is the commonest STI in both men and women. And in the majority of the people, it is asymptomatic. Some of the risk factors, early sexual debut, having multiple partners, concomitant STIs. Basically, these are things that are associated with high exposure burden to multiple partners. And therefore, people who have these features are more likely, populations who have some of these characteristics are more likely to have HPV infection. And as we mentioned a little bit earlier, the majority of them resolve within a fairly short period, like 2 years. 90% will usually resolve. And 10% will develop some form of neoplasia, like the one that I just showed here, the precancer stages. And then a very small proportion, less than 1%, will develop full-blown cervical cancer. So yeah, this is sexually transmitted, and it is mainly through direct contact, but it can also be transmitted vertically to the unborn child. There are studies that have reported isolation of HPV in newborns, and that has been associated with having a mother who is actively infected. And in Kenya, the prevalence is around 40% prevalence of HPV infections. And for some reason, this the incidence, the acquisition of HPV infections seems to peak at 25 years. You can imagine this is a time when most young women are becoming sexually active, and for some reason also at 55 years. And this is thought to be because of the hormonal changes and the physiological changes that are associated with menopause, and therefore leading to higher chances of viral shedding. So we talked earlier about high risk and low risk types. And the high risk types, some of the high risk types are actually the most studied ones are HPV 16 and HPV 18. And these are associated with the majority of cervical cancers. Actually, 70% of cervical cancers are associated with those two HPV types, which are high risk types. And then you also have the ones that lead to warts and are rarely associated with the cancers. And these are HPV 6 and HPV 11. And these are present in the majority of the anogenital warts. So as we have talked so far, the main manifestation of this is the warts and cancers. So you have what we call the anogenital mucosal warts, and then which we call condyloma acuminata. And then you have the non-anogenital mucosal warts, like in the oral compartment and also in the oropharyngeal regions. And then you have the cutaneous ones, which will be associated with the warts in the rest of the body on the skin. And then the cancers are not limited to just anogenital warts, but you can also have oropharyngeal cancers that are associated with HPV. And then also you have, in very rare cases, skin cancers. And then you can also have some genetic manifestations of poor immunity to HPV types that are associated with the skin infections, the skin warts. And that can lead to what we call epidermal dysplasia, the riciformis. Basically, you can have uncontrolled warts where the body has immunological defects, probably due to genetic mutations. So this is just showing how some of the warts on the skin will look like. These are the common skin warts. You can have some of them being what we would call flat warts. And this is the genetic predisposition to warts that can lead to that condition that we call epidermal dysplasia vericiformis. More pictures on other cutaneous warts. You can see plantar warts. this ordinary warts on the feet, hands, and skin are fairly low risk, with the exception, of course, of the genetic predispositions in some of these very rare cases. So even in the mucosal compartments, the presentations are very varied, and this is mainly because the body is the one that will determine the progression of these infections, because most of these infections are controlled by the immune system spontaneously. So you can have anogenital warts that are presented in the genital regions, in the vagina, labia, vulva, penis. You can also have the ones that are are presented in the rest of the skin. They could be smooth, they could be keratotic, and these are generally mainly painless, but they could lead to complications depending on the location of the warts, especially if they are exposed to friction. So generally, so these are the diagnosis of HPV. Most of the efforts have been invested in diagnosing genital infections that are high risk. But also this extends to the other HPV types. So, and then these are the main laboratory diagnosis techniques that we use. You can either test for the HPV DNA, and now we are also having mRNA testing to test for the mRNA that is being produced from these infections from the HPV genes. So that is a fairly easy strategy, because even patients are able to collect these samples themselves and then send them to the laboratories. So that's fairly easy. Then we have the cytology that is usually done during pap smears, where they're able to look at the cervix and also collect some cells that can then be checked whether they have infections. And that has been quite commonly used as a screening test. And then you can also have, especially in people who have been seen to have suspicious cytology outcomes, you can also have some tissue biopsy being taken and then being sent for histology. And this can be done when they're able to do a little bit of opening of the vagina to be able to inspect the cervix under some magnification levels, and then be able to collect the tissue biopsy and send it to the lab for histology. That is usually done for better classification if they have seen any lesions. And then you have also the visual inspection, like the images that I showed you earlier, for how HPV infection in the cervix progresses. This can be done by staining the cervix with the acetic acid or Lugol's iodine, and this can also be used for the others, but mainly for the cervical inspection to be able to see whether there are some lesions. So as we talked, we said earlier, if for most of the viral STIs, there is no cure, and the main aim is usually to reduce the symptoms. And in some cases, also where some antiviral drugs are available, we also usually aim to reduce the viral loads so that we can reduce transmissions. But for HPV, our main aim is to just reduce the symptoms. And this will, of course, depend on the site and also the magnitude of the infection. And because we are not curing, treatment could happen again. But the body is able to eliminate the immune system. The body's immune system is able, as we said earlier, is able to eliminate viral shedding in 90% of the individuals. And that is for the for the cervical HPV infection. But for the others, recurrence is fairly common, and so it shouldn't be a surprise when someone needs some retreatment. So for that symptomatic management and also for keeping down the viral levels, we have various strategies. We have the pharmacological agents that can be used to boost the immune system. And some of these agents, like the immune modifiers, they basically boost the immune system, and they do this by inducing the immune cells to produce antiviral agents. So like for imiquimod, this agent usually stimulates some immune cells to produce interferons, which are soluble factors that are able to fight viral infection. So this is not the direct factor that fights the viral infection, but it activates various immune cells so that they can produce soluble factors that are able to fight the infection. We also have instances where the actual antiviral factors themselves are also administered to try and control that infection as biological agents, like interferon alpha, which is a cytokine. In fact, actually, imiquimod usually induces cells to produce interferon alpha and other related interferons. We can also have cytotoxic agents that are able to control cell replication, and therefore they can be able to control these warts that are growing in the genital areas. And some of these are like podophylox and podophyllin, which are related. And then you can also have 5-fluorouracil, which are able to suppress cell replication, being antimitotic drugs. And then you can also have some other agents that just directly erode the warts in the case of warts, like salicylic acid and trichloroacetic acid, which are able to just physically erode the warts. And then the other treatment type is surgical. If it's a wart, you can have it removed. If they are genital warts, they can be removed by just simple surgical excision or using other sophisticated surgical procedures like cryosurgery, where you use very cold liquid or very cold objects to destroy the tissue that is affected, or electrosurgery, where you're using electrical methods to remove that, or laser ablation, just to remove the affected tissue. Similarly, in cervical cancer, you have removal of the infected tissue in the cervix, or in the event that the cervical cancer spread all the infected tissue, the aim will be to remove all the infected tissue. So we usually have a lot of hysterectomies that are done to correct for that, to try and manage cervical cancers. So prevention, we have had a lot of efforts being put by the government and also non-government entities to educate people on HPV, to educate people on cancer, cervical cancer, what causes it, what are the preventive measures that are available. And also the other one is by practicing safe sex practices, the safest being abstinence, of course, but also managing how people practice sex by avoiding multiple partners and also late debut, sexual debut. But because HPV is transmitted through skin-to-skin contact, condoms are only partially protective. They only protect as much as they are able to protect skin-to-skin contact. And then the most effective prevention that has been developed recently are the HPV vaccines. And here we have quite a variety of HPV vaccines. We have the bivalent vaccine, going by the brand name Severix, which is able to induce antibodies And those antibodies are able to protect people from acquiring HPV-16 and HPV-18. And then you have the quadrivalent one, which is able to protect against 4 types, 6, 11, 16, and 18. So you'll notice that 6 and 11, we said these are the ones that cause genital warts, while 16 and 18 are the ones that are associated with cervical cancer. So you can see that the quadrivalent vaccine is targeting both the genital warts and the cervical cancer causing types. And which was omitted here because there are some considerations that genital warts are not really life-threatening. They are mainly a cosmetic issue. Because I mean, nobody wants to have them. But the main reason why these vaccines were developed was to actually target the types that cause cervical cancer. And then now we recently have this upgraded Gardasil 9, which is covering many other types, some of them covering more on the high-risk types. So that's it for today. It's fairly simple. And I don't know whether you have any questions. Oh yeah, I can see a lot of discussions in the chat. Let me look at them. Anyone who wants to highlight any question that they want us to discuss from the chat, I can see there's a lot of discussion that has gone on there. Okay, someone is asking about precancer. Yeah, chemo is only done when you have actual cancer, not in precancer. So yeah, because remember, most of those precancer conditions, they're able to revert backwards. And therefore, it is not necessarily for someone to get cancer treatment when you are at this stage, at the precancer stage. You can see that there are so many cases that will be able to regress, but what they will do is to monitor that person very closely. And so very, very close monitoring is what is done. But they will also remove, cut out the infected, in some countries, I know they cut out some of the infected material to try and minimize progression. Oh yeah, I can see actually Kamunya has actually answered what I've just added. No, not everyone will have precancer cells. It's just a few people. So someone has asked whether I can show a picture of the virus. This is basically a very simple cartoon. I don't think I have the actual picture of the virus anywhere. But it's a fairly small virus anyway. Yeah. So I think I removed a picture that was showing the genome. I can try and look for it and put it in there before we finish here. Is smegma a reservoir of HPV in uncircumcised males? I'm not sure about that. I would need to check whether we have evidence for that. Yeah. Does anyone know? Does anyone know if we have evidence on whether smegma is a reservoir of HPV in uncircumcised males? I think, and I can see someone here who has asked vertical transmission for me to explain vertical transmission. Vertical transmission is basically transmission from mother to child, either in utero or during birth or during breastfeeding. So this is the one that we talk about a lot in HIV, but it also happens for other STIs. So someone asks, should they wait for cancer then? No, what usually happens is very close monitoring. And also in some settings, some of that cancer, pre-cancer tissue is removed through very simple excision of just the region that is affected. Yeah, so monitoring and in some settings that pre-cancer tissue is removed. So is the cancer in other sites as a result of metastasis or transfer of the infection? It's mainly metastasis. Because remember, HPV has tropism for the cervical tissue and also some oropharyngeal tissue components. So that means that those are the ones that will harbor the infection, but the cancer is what can metastasize to other regions. So what do we do, sir, if during delivery and a woman has the precancer cells and says she didn't attend clinics? If a woman has precancer cells at any time, the best you can do is to have them referred for close monitoring, and then the gynecologist can determine whether this person needs to have excision of that tissue, of that small part that is affected. Is transmission 100%? We think transmission is quite high because when you look at, we will never know whether it is 100%. We'll never know that, but the transmission rates are very efficient because a big proportion of young women will acquire HPV at some point at around 25 years or thereabouts. So suggesting that just sexual debut itself leads to a big proportion of women getting HPV infected because it's so common. And that's the reason why the HPV vaccines are targeted for much, much younger girls who have not had sexual debut, because any delays will mean that by the time you are vaccinating the girls, chances are they have already been infected or exposed. Yeah, cervical cancer can metastasize. Yes. How soon it can be infected? It can be detected in an infected individual. We will never know. We don't know, because it depends. It will be difficult for us to know when someone was exposed to it by the time we detect it. Yeah. So the much we can do is to approximate, but we will not know. Why is E6 and E7 implicated in carcinogenesis? Yeah, those proteins are associated with, they have a high likelihood of modifying the cell mechanisms that prevent cancer development. And that's how HPV is thought to cause cancer, because it interferes with anti-cancer mechanisms that every cell usually has. So that's how we think E6 and E7 could be leading to that. Those are two proteins that are thought to be drivers of the pathogenesis. How does early coitus increase the risk of contracting HPV? This first is related to early coitus is associated with being more sexually active at that stage, but also younger women also have poorly developed cervix, and that changes the dynamics. What's the time between precancer and cancer stage? This is very varied, because some people are regressing, others are progressing, so you wouldn't know. The best to do is to have close monitoring. even after removal of the infected lesions. Can HPV cause penile cancer? There are instances where it has been said that it can cause penile cancer, but I don't know how much evidence there is on that. I'll need to find out. But that's not one of the main implications, main consequences of HPV infection on the male. We don't usually think about penile cancer. Incubation period. So what usually happens is when someone gets infected, maybe at around their sexual debut, early 20s, the majority of the people will clear the infection, and then a smaller proportion will have persisting infections, and these people start having cervical cancer, diagnosis, even decades later. So it can remain there, persisting in replication in a small proportion of people, but the majority will clear, of course. And some studies have associated that with the higher likelihood of developing the cancer. And that's the reason why when the cancer develops later, most of the cancers are associated with an HPV infection with the high risk type. Can HPV cause erectile dysfunction? No, it can't. Not as far as we know. Yeah, the incubation is many years. Because you can imagine most of the people get infected in their mid-20s, and we only start seeing cervical cancer cases in 30s and later on, mostly. At the stage where there is epithelial neoplasia, can regression occur even without any medical intervention, or when unscreened is assured to progress forward? No, it will not always regress forward. It can regress. It will not always progress. Can HPV vaccine be given to a lady who has started having sex and is still effective? We are wondering whether that's the case. Actually, that's what everyone is wondering. And that would enable us to use it in older women. But the thing is, that vaccine only prevents infection. It is not a curative vaccine, it's a preventive vaccine. So if someone has already become sexually active and they have already acquired an HPV infection, this vaccine, because it induces antibodies can only prevent acquisition of new infection. So that means that that person will have lost an opportunity to benefit from that vaccine. But there's very, very scanty evidence on how many people at the older age groups have never ever been exposed to HPV to warrant us rolling out that vaccine to all age groups. So that is still fairly a new area that the scientific community is trying to see whether we can have catch-up campaigns even in all age groups. No, you don't need broken skin for skin-to-skin transmission. HPV is very efficient just through skin-to-skin contact. Yeah, most skin and genital warts regress spontaneously. Yes, but we still have those pharmacological interventions for genital warts and also the skin warts when they persist, and also when someone wants to hasten the clearance. That's the reason why we have some of those pharmacological interventions. How does smoking increase risk factors for HPV? This is purely because of all the impact of smoking on the general well-being of the immune system, and that's how smoking also ends up leading to higher likelihood of developing cancer, because All these are controlled by the immune system spontaneously. Is HPV vaccine available for males? Not in Kenya. In the West, there are some countries that are giving it to boys. Yeah. And the thinking is that this will protect them from the oropharyngeal versions of HPV, as well as protecting them from acquiring HPV and transmitting it onwards to other women. So any other question that I've not addressed, you can always post it at the bottom of the chat. How soon can HPV be detected in an infected individual? That one we will never know for sure, because we don't know when someone got infected through sexual contact, because it's difficult to track that. There are estimates, but it is difficult. But what we know is that HPV detection seems to be coinciding with the beginning of sexual activity. So that means that the estimates suggest that HPV can be detected soon after sexual exposure. Is it true that HPV is more prevalent in low socioeconomic status areas? I don't think so. I think it is just associated with sexual activity. Unless different economic strata in the society have different uptakes of the HPV vaccine as we go forward. That could be a major drive of differences between different strata in the communities. Okay, someone wants to take a snap of the slide showing the precancer. So you can take a snap of that one, and the next one, I'll show you the next one. Then you can take that one. This one, I got it from the ministry. There are some workshops that we are planning to do for healthcare workers in the community. So this shows the general progression. With regard to early coit tracts, I talked about the poorly developed cervical tissues that could be more easily infectable with the different pathologies in younger women. And also the fact that early debut will be associated with sexual activity, early sexual activity and more prolonged exposure. Okay, so we can close this class. So what we'll do is we can start the other class at 11 so that we can have some break in between. So you have a 1 hour break. Enjoy your break. See you at 11.
Thank you.